So another challenge in the field of stem cell transplantation using unrelated donors, haploidentical donors, is reactivation of a virus that many of us have. 60 to 70% of the population will have been infected with the CMV virus. It doesn't cause us any trouble until you suppress the immune system. When you suppress the immune system, it can reactivate and actually become a disease and cause pneumonia or inflammation in the brain, in the intestinal tract, and the liver. So it can be a quite serious disease when it occurs. And so we have therapies, a drug called letermovir that help prevent the reactivation of this disease or delay the reactivation of the disease. We have drugs that are effective in treating it if it does reactivate. Those drugs have a lot of toxicities, particularly those that we use to treat activated cytomegalovirus or CMV infection and disease. And so in this study, we looked back to see, is there a significant difference between well-matched unrelated donor transplant and haploidentical transplant? For some reasons, including those that have been published in the literature, there is an expectation that we would see more CMV reactivation after a mismatch or haploidentical transplant than after a match unrelated donor. But we looked at 452 patients over a 5-year period in our center, single center, and did not see any significant differences between match unrelated donor transplant and mismatch or haploidentical transplants in CMV reactivation or disease. Further, we use a drug called cyclophosphamide to prevent graft-versus-host disease after haploidentical transplant, and because of its success in doing that, it's moved on to other settings like match unrelated donor transplant. So we did a subset analysis of patients who had received the same graft-versus-host disease prophylaxis regimen after unrelated donor transplant and haploidentical transplant, and there too we did not see a significant difference in the incidence of CMV reactivation. Finally, the drug letermovir that we're commonly using to prevent CMV reactivation, and particularly in high-risk patients, did not make a difference. What we did see was a shift to later CMV infection. But overall, we didn't see a difference in the incidence of CMV infection or the incidence of disease. The only thing that seemed to make a difference was a CMV positive recipient versus being negative. There was a much greater risk of CMV reactivation, not surprisingly, in patients who were CMV positive. And additionally, we saw a significant difference in different ethnic groups. So African Americans and Hispanic Americans were much more likely to have a CMV infection and disease than their Caucasian counterparts. And we believe that this is because of their prior exposure to a CMV infection. It appears to be higher for some reason, 80% in these minority populations compared to about 55% in Caucasians.